Okay, good morning. Cameron MacLeod is currently the Executive Director of the Carlington Community Health Center, and he's been working in the health and social service community since 1984. He holds an undergraduate degree from Carleton University in law and sociology and management certificates from Queen's University and the University of Toronto. Cameron's work life has been primarily in children's services, where he was an advocate for children and youth in the child welfare, mental health, and youth justice system. He has a strong interest in promoting integration and cross-sectorial collaboration in order to optimize the scarce resources and increase access to services. Cam started the SWAG program. Students will all graduate about 5 years ago. This is an afternoon program or after school for high school students living in social housing. And this is so they can get good grades and have a chance to go forward to college or university.
Okay, good morning. I'm going to share my screen and then we'll get on with it. Is that good? I'm going to take that as perfect.
Yeah,
thank you.
Good.
Great. So good morning, everyone. Thanks for your time this morning. I've been tightly scripted, so I will be going through these slides. If it does seem like it is a little bit quick, please be patient and I'll welcome questions at the end. Thanks for having me this morning. I hope everybody's well during these COVID times, and I look forward to, as I'm sure you all do, getting out the other end sooner than later. So, what I'm going to talk about today, I'm going to take you on a little bit of a trip down memory lane from 1984 when I started at Children's Aid to today. Look a little bit about my jobs and what I've garnered from them. I'm going to talk about a book that was written by a gentleman called My Lobotomy, which might seem a little bit odd, but it has influenced a lot about the way that I look at the world through the eyes of kids and in looking at the way programs are developed. And then at the end, I'm going to talk about how the CHCs, community health centers, have been engaged in activities and promoting crime prevention through our programming. Whoops. So I want to put up here, I'm not an expert in anything. I have a lot of lived experience for sure. I have a PhD from the University of Hard Knocks. I'm not an academic. I'm not going to be tossing out all kinds of statistics at you. I'm going to talk more about observations and experiences, what I've learned from the kids and people that I've worked with through my working life. And certainly I've learned more from taking the time to speak to kids and families than I ever did in books. I was a terrible student. So really I've done all of my learning on the job, and I will tell you some stories to punctuate my points. So this is a bit about my resume. I'm not going to read through it, but if you looked at my CV, you'd think I couldn't hold down a job. But what I did want to emphasize is that I have had 3 executive directors positions over the years, and it's really helped me learn about leadership and how to make the changes that I want to see in the system. I'm going to tell you a story about a kid named Junior. And I learned a lot from Junior. I met him in about 1991 when I was working at the Ottawa Youth Detention Center. He came in from Regent Park, a black kid. Dad was Jamaican, mom was white. And he came on an assault charge. And at that time, there was all kinds of stuff going on in the system. The justice system was getting really used to using the Young Offenders Act, and we were getting kids being sailed around the province in all kinds of different ways. When I first met Junior, I thought this is going to go really, really well, or it's going to go really, really south, because he was a kind of a cocky kid, movie star smile, really, really smart, built like a truck. And you could see that he had really good interpersonal leadership skills. One day he was taken to court by officers that I knew to be racist, and he was taken with another youth who was actually of Haitian descent. And when they came back, I could see they were very angry, and it became apparent to me right away that something had happened while at court. Normally the kids would take off their jackets and their handcuffs and that sort of thing from the escort in the front lobby of the detention center, and then they would just go down to their rooms. They both refused. So one of my staff took Junior down one wing of the building, and I took the other one, who I'm going to call John, down the other wing. We got them all unbuckled. I apologized for the way he was treated and said that I would follow up. And as I was walking down to his room, he said, "I'm not going to my room." And he turned around, and I made the mistake of touching him on the shoulder, and he hit me 5 times square in the face as hard as he could. And after I got him under control, I made the comment to him that, geez, if you're going to continue down this path, you're going to learn how to hit harder, because you just smacked me 5 times in the face and I'm still looking at you. So Junior that day had a really tough night, and we had to transfer him to the regional detention center because we couldn't keep him safely anymore. We kept in touch through probation officers, and about 2 years later, I heard that he was killed in an incident at Ontario Place. Fast forward 20 years, I was coming out of my Metro store in Orleans, and there was a booth set up to make donations. And there was a gentleman standing behind the booth, and I started asking him about his organization because I had never heard of it before. And I've been doing this a long time. And he said, "Well, we do work with inner city kids in Toronto. We do after school programming. We do relief work in other countries with the kids." And he said, "Did you used to work at Bronson," which was the name of the detention center? And this guy was massive. And I said, "Absolutely." And he said, "Well, do you remember a guy named Junior?" And I said, "Absolutely." And he said, "Well, that's me." So I was a little bit gobsmacked because suddenly he'd come back to life, and I asked him what the story was. Turned out he didn't get killed. He actually was charged with second-degree murder and spent some time in the Don jail. And after 8 months, he was exonerated, and he got out, and he decided he could go back in by continuing the life that he had, or he could smarten himself up. And he decided to become a pastor. And he got on with a missionary group and traveled all through Canada and the United States preaching. And when he got to Alabama, he decided this wasn't his path. So he jumped off, went to the University of Alabama, got a business degree, moved back to Whitby, was in the gym getting huge, hurt his back, got physiotherapy, fell in love with the physiotherapist, moved into a beautiful home in Whitby, and he was the executive director of the organization that was raising the money. So all of a sudden, the kid that I knew in 1990 was a peer executive director. So the lesson learned there was never underestimate the brilliance and resilience of youth, and trust that adult relationships matter, because he told me things that I said to him that I never imagined he would remember, and that I certainly didn't. And then he spoke at my annual general meeting in 2012. And the fellow on the right is John, who is now a professional mixed martial artist. Then I moved to the Robert Smart Center, where I read this story called My Lobotomy. And in brief, it was a story about a fellow who at age 12 was a bit of having some troubles. He was in trouble with the law. He was in a broken family. His mother had, a reconstituted family. His mother had died. His dad had remarried, and they desperately tried to get help for this kid. He saw a number of psychologists, psychiatrists. They didn't help. So they took him to a neurologist, who decided that he was a candidate for a transorbital lobotomy. I'm not going to explain that to you or describe it. Let's just say it's gross. He was lobotomized at age 12 as an experiment, really, to see how it would impact his behavior, but also to check out neuroplasticity, which is the capacity of the brain to heal itself around wounds. The good news is neuroplasticity works, and he actually went on to live a rather normal life. The bad news is that he was lobotomized at age 12. So as I got thinking about this, I started thinking about, what are we doing now in 2020, 2021, that we're all going to look back on in 30 or 40 years and say, what the heck were we thinking? So at the Robert Smart Center, we were right into physical restraints of kids. The lobotomies for me right now, the things that I look back on with a little bit of shame, is physical restraint and the use of psychotropic medication on kids. We started a new program at Robert Smart called Collaborative Problem Solving, where the kids are actually engaged in their treatment in a different way. In the first 5 years of that program, we went from 328 physical restraints to 326 to 151 to 93 to 51. So we had a many-fold decrease in the number of times kids were restrained. The other implication of it was the next numbers you'll see down below. We went from 76 staff grievances in my first year at Robert Smart to 1 in my last year. So by doing better by kids, we did actually better by staff. So the lesson learned was kids can do well. Kids will do well if they can, but really it's on us as caregivers to make sure that they can do well. So this is my last ED job. What I've learned so far in this job is how to politic, the importance of being able to work with our elected officials and bureaucrats and the social determinants of health to make sure that people that are struggling actually get a chance to do better. And what I've also learned is that systems that should be working together do not. Case in point, the kids' mental health system does not work well with the adult mental health system. So this is our center, right at the corner of Merivale and Coldry, just south of Westgate. So we talk a lot at Carlington and community health centers about equity versus equality versus social justice. We really are striving for equity. The reality is that on the left-hand picture, a few people and sometimes people of privilege have all the resources. Equality is we spread the resources out and give the same number of resources to everybody. And what you see in that second photo from the left is that that's all good, except that the more privileged people again benefit. Equity is when resources are distributed so that everybody has equal opportunity. And then the last slide, which is my favorite, social justice, you actually remove all the barriers and everybody has equal opportunity. And in an ideal world, we don't need these extraordinary resources. Just a little bit about Carlington. We've made a commitment to truth and reconciliation. We were named by an Indigenous elder, the Circle of the Sweetgrass, and we're really pressing on training our staff and trying to be more culturally sensitive and culturally safe for our Indigenous people. And the cool thing about my job is sometimes I get to meet really important people, and I've met a lot of important people, including Prince Edward, and I was never more nervous to meet anyone as I was to meet Senator Sinclair. So a little bit about our money. Our operating budget's about $8 million. We get about $5.5 million from the Ministry of Health. We get just over $1 million from the City of Ottawa, and the rest is dribs and drabs that come in from other sources, other ministries, and certainly we're always writing grant proposals for funding from various foundations. One of the things that we were really involved in the last few years was the welcoming of the Syrian refugees. And what was really interesting that I learned about these folks, the women, number one, wanted to learn how to speak English. The men, number one, wanted to have a job. So we helped at Carlington about 266 individuals over 3 months. And the good news is that they're all, as far as we know, are all housed at the moment. And we know that they're also getting into the jobs, the employment systems, and the women are taking ESL classes. So we've checked a couple of boxes as our Community Health and Resource Center network responded to that, in fact, that humanitarian crisis. The other thing that we do is we look after our seniors, and these are just examples of a couple of things we do outside of our child and youth programming. People that have been by will know that we have a large building now that we've appended to our old building, and we have 42 units of seniors apartments there, and these are the folks that we've been serving. So we're part of something bigger. The Ottawa Coalition of Community Health and Resource Centers, we're 13 strong. We go from coast to coast in Ottawa at both ends, and in the south, we serve rural populations. We support a lot of smaller agencies because we do have a big footprint and we do have more resources than some of these smaller organizations. We do step up and try to support the more grassroots organizations in our communities. And we're very politically active municipally. We're the ones that are driving things like social infrastructure investments, housing investments, and during the pandemic, absolutely, we've been looking at things like food security and isolation. Those are the kind of items that have been at the forefront for us over the last year. So a little bit about our clients at Carlington. So by age, 16% are over age 60, 21% are under 12, and everything in the middle. Demographically, it's not much different than a lot of communities that we all live in. Gender identity, we are heavily skewed with female clients. That's probably a lot to do with our early years programming, where moms tend to bring their children to our play groups and seek out family supports in that way. We have a very strong maternal health program that we invest heavily in, and we want to continue to promote that. Household income. This is a bit of the shocking point. This is where we get set apart from other service organizations. 70% of our clients earn under $30,000 a year. And we were talking when we were getting ready about our tax clinics. In order to qualify to have your taxes done at our tax clinic, you must earn under $30,000 a year. When you consider that the N here, the number of clients that we serve is north of 6,500, that's an awful lot of people that are living with low incomes. Education level, on its face, this doesn't look too bad. With almost 50% of the folks that are our clients have post-secondary education. The fact of the matter is a lot of these folks got their degrees and diplomas in other countries and they're not recognized in Canada. So these are the folks you hear about where, you know, doctors are driving taxis and that sort of thing in order to bring in income. So that's something that has been a bit of a sore point. And I know United Way, for example, has been doing a lot of work in the last 15 years to try and get credentials of foreign trained workers recognized and activated in Canada. This is a country of origin outside of Canada. So what you see is quite the pinwheel here of countries of origin for folks that come and seek our services. We've capped over 140 languages. We've identified over 140 languages and dialects spoke in our center. Right now, when we do outreach to clients, we're reaching out in English, French, Arabic, Somali, Spanish, and Chinese. So those are where we try to retrieve our information, but there could be certainly a lot more forms, but we wouldn't get a good return on investment if we translated it into 50 languages. So I've noticed over my time at Carlington and certainly over the course of my career that there's parallels between the health and justice systems. In universal healthcare, folks probably know about Tommy Douglas in 1962 that proposed universal healthcare. The first phase was to build a great acute care system to keep people, help people that are sick get well. So therefore we had a lot of hospitals built and we have a really good acute care system in Canada. Some people might argue, but my experience has been that if you need help at a hospital, you generally get it. Phase two was supposed to be to build a system of prevention, a system to get upstream and actually prevent people from getting sick in the first place. And I think, frankly, this is where we've fallen down. And this is where community health centers have really tried to insert themselves in making sure that folks that are struggling against the social determinants of health get the help that they need in the best possible way. In the justice system, we've been really, really successful at building jails and locking people up. And as I said, in the early 90s, certainly kids were being incarcerated at an outrageous rate to the point where we were overwhelmed. The detention center I was working in at that time had 14 beds, and it wasn't unusual for us to have north of 20 young people sleeping on mattresses and waiting to go to court. So we've only really recognized the importance of prevention work in my mind. And again, this is anecdotal and this is my editorial comment. Only in the past 15 to 20 years have we really done a good job of making good investments in mental health and looking at community-based alternatives to incarceration of kids. The interesting thing about kids is when we brought them into our detention center, we actually did care about them. And I'm quite proud of that fact. And they all did well. To a person, those kids did well. The problem was that when we turned them back loose, there wasn't a safety net to catch them. What I also learned is that Canada is leading many other countries in the use of things like pre-charge diversion and sanctions and options outside of the formal court and charging system. We still have a long way to go, absolutely, but we've seen a huge drop in the number of kids being incarcerated over the last number of years, and we have seen those funds reinvested in community-based programming. We need to continue to pay special attention to segments that are disproportionately impacted. This should be no surprise. If you look at our justice system, and I think Dr. Waller would, hopefully he would agree, is that disproportionately impacted populations are certainly the Black population, the Indigenous population, the newcomer populations, who are often coming from situations where their justice systems have been in disarray, if there has been one at all, and they're coming and trying to integrate into Canadian justice and Canadian social systems, and they're unable to do so because they don't have that frame of reference. So Young men, I, again, anecdotally will say that we worry about young men in our youth justice system for good reason. They become disenfranchised. Because of the way families have been broken over the last number of decades, for sure, where family separations become more mainstream, for lack of a better word. There's been a lack of male role models in their lives, certainly in the homes. They look to alternative structures such as gangs to feel included, feel affiliated, feel powerful. In Ottawa in the early 2000s, we worked with a number of community partners to put together a gang strategy. And part of it was around enforcement. And at that time, it wasn't really a problem. In the early 2000s, gangs we sort of saw them coming, but they weren't here yet. Now they're here. And we were in fact out of the blocks early, but we're still having trouble putting an end to them. We do have a guns and gangs unit in the Ottawa Police, but outside of that, the social service organizations have gang exit strategies. And also there's programs that identify the younger brothers of gang members to try and prevent them from getting on that trajectory into gangs. Gangs are predominantly of interest to racialized males. There's a mistrust of police. Systemic racism absolutely plays into it. And I think about the first young men that I met that came from Somalia in the early 90s and how they were subjected to treatment by people in uniform. And when we started seeing young men coming into the detention center in the early 90s, a lot of it was striking out against police and others in uniforms because that was their frame of reference. Young women, in my experience, young women in the justice system are almost always living with trauma. And sometimes they don't realize it. Sometimes trauma has been normalized in their life, so they don't see themselves as victims, even though their behavior and their life circumstances indicate that they had been victimized. High rates of victimization and abuse within the young women's populations. Their offenses are crimes of survival. And I talk about, sometimes they're assault charges where they're fighting back against perpetrators. Sometimes they're shoplifting to get food and clothes. What I found the most was the young women wound up in a higher level of custody simply because they ran away from lower levels of custody, and was almost a case of frustration of the court system not knowing what to do with them. A lot of the young women that I encountered over the years were involved in the sex trade, often from a very young age, and I'm talking like 10, 11, 12. And many of them were involved with child welfare. So over the years, what has changed? I think we've re-looked at the way that we deal with kids, because we talk about rehabilitation, but really it's been about habilitation. We assumed skills were there in the first place. We had to give them back. The fact of the matter is that they didn't have the skills in the first place and we had to teach them. So that's a significant shift. Legislative focus has changed from a place where kids were seen as needing structure to a place where kids are now actually engaged in their treatment and in their interventions. Mental health has become front and center. Stigmatization of people with mental illness and mental health issues has been something we've been trying to overcome actively and intentionally, certainly over the last 15 to 20 years. We've started to really engage parents as partners in interventions and focus on education and really not seeing high school graduation as the finish line, and that's really important. Patience is key. I'm going to skip over this one because I know I'm running out of time, but when I was teaching at Algonquin College, there was a lot of idealistic students that were going to go and change the world, and my message to them was, be patient. Rewiring these kids is going to take some time and some patience, and sometimes you're not going to know for years how you actually did. At Carlington, we pay strong attention to the social determinants of health. I won't read them out to you. Hopefully none of these are a surprise. These are the things that people struggle against in order to make gains in the world, in life, and these are the things that present barriers. So we follow the evidence at Carlington and at other CHCs. We want to know what the research is telling us, and we frame our programs based on what we've heard, and we put that research into motion. Also, we're really intentional about reaching out to our communities and our clients when we're putting our programs together. And we also are a teaching center where we bring students in and we give them real life experiences so that we can turn them loose and they'll be better equipped to go out and do the helping that they want to do. Crime prevention through community development is really important. Investments in communities where evidence indicates there's marginalization has been key, and we've seen a number of opportunities or another of examples in Ottawa where this has been done. The city's made investments in at-risk communities. The police have made investments in at-risk communities. And we pay attention to the social determinants of health in those communities. So it's working with communities and not for them. It's going and asking, what do you see as your number one reason or your number one issue? And we work on those with them hand in hand and co-design the approach. My analogy that I used for the students were seagulls in oil slicks. We go, we find a seagull in an oil slick, we take it away, we clean it up, and then we turn it loose. But if we don't clean up the oil slick, then within a short period of time, that seagull is back in needing to be cleaned up again. And kids are like that. We rarely saw a kid for the first time in our detention center. It was a revolving door. The problem is every time they come back in, like a seagull, the feathers are a little bit more wilted and they're less amenable to change. So it's important that we clean up the communities. We work in the communities where these kids live in order to make it a more habitable for those kids when they go back out of custody or when they return from other circumstances. Start early. What we've learned is that infant mental health is really important. We actually, in our early childhood and our maternal programs, we look at mom's mental health and we work at the stressors in their life so they can be more able to parent once their children are born. We look at ACEs, which are adverse childhood experiences. We know that childhood trauma is a big driver of good child development and ultimately health and social outcomes. And we now in our early years programs, our Head Start Nursery School, we look at ACEs and we look at mitigating strategies. I want to talk a little bit about SWAG. Students will all graduate. It's an example of a multi-pronged approach, which actually we believe is actually a crime preventive measure because it takes kids out of critical hour circumstances where they're unsupervised and they have nothing to do and they're making things up, and it gets them into a place where they have good adult role models and good supports for education. So they get academic support during critical hours from teachers. This is a partnership with the school board. They have access to positive role models. And what we've really tried to do intentionally is have the role models look like the kids. I'm going to show you a picture in a minute. The kids are Black and the teachers and staff tend to be white. We're really looking, and the kids have asked us, please get people that share our life perspective, get people that look like us into these programs. It gets them a place to celebrate successes and to be recognized, and it allows them to dream big and look beyond high school. Every kid that leaves SWAG and wants to go on gets a scholarship as a little bit of a boost to get them going. Since we started the program, we've had over 120 students enrolled. I believe we're up to 135. To date, we've celebrated 61 high school graduations. Another 23 will graduate this year. 45 of those 61 have actually gone on to post-secondary education, and we consider our success rate based on our dropouts at 90%. It's about keeping these kids engaged, keeping them in school, keeping them in a situation where they feel like they belong and where they feel like they're succeeding. So here's the kids. The teachers kind of stand out, but as I said, we're being very intentional about making sure that the people that we attract to the program to be volunteers, to be students, and to be staff are people of color, and they can actually share life experiences with those kids, and the kids can feel safe going and speaking to them about racism and how they feel and what their life experience is as a person of color. So what we need to do is demystify systems. The justice and mental health system are complex and complicated. Entry points are difficult to find for everyone, even me. So we're working hard right now as a sector, as a group of caregivers to make mental health system more accessible. You probably may have heard about Kids Come First at CHEO doing one call, one click. We've started Counseling Connect as a result of the pandemic, where people can actually go online, sign up for mental health services by themselves. We're looking at regional coordinated access for mental health services that's being rolled out through the Royal. And actually the pandemic, the silver lining is it's making us work together in ways that we haven't done before. So I'm optimistic. So here's my shameless plug. People that know anything about Carlington will know that it's the little schoolhouse at the corner of Coldry and Maryvale. We've done a massive extension. We opened our new clinic in October, which is on the ground floor of the new structure at the top. It's amazing, if I do say so myself. And the other piece that we're doing now is we're renovating the interior. And the idea is that all of our client-facing services will now be on the ground floor, and we won't have to have people going upstairs and using elevators to get to the services that they need. It also is giving us much, much more space for community use and for our staff. So far we've spent about 25 million bucks. We've got the new clinic, and on top, Ottawa Community Housing built 42 units of affordable housing for seniors. And we're, as I said, we're expanding our space, and all being well, we'll be done in 2022. That's what it looks like now. So it actually looks like the picture. And I'm going to stop there. I think I'm actually kind of on time, so that's unusual for me. So I will open it up for questions.
So Anita, I've unmuted and spotlighted you. Folks, please send your questions via the chat to Anita and she'll pose them to Cameron.
I think there were 3 questions from Irvin during the talk. You have to unmute yourself, Irvin.
You want me to read the questions? I've got to find them. Okay, I'll start with the last one. You talked about poverty and inequality, mental health, education, and parenting. If you were city council, how would you use 30 million a year to decrease ACEs to prevent upstream crime? That's to invest in upstream prevention to stop crime.
So, yeah, I mean, that's an interesting one, Irvin, because there's this tension between who does what in terms of funding, right? The city does this and the province does that. We've been pressing the city for the last 5 years really intentionally around what we're calling social infrastructure investments, which is what you're talking about. We've narrowed the definition of social infrastructure to be those social services programs that are serving the most vulnerable. If I had $30 million, I would make significant investments in housing and housing supports. We know that, you know, and there's the initiative called Housing First, where where it's been defined that housing is the #1 predictor of good health and social services outcomes. Like if you can house a person stably in a situation where they can afford it, they're going to do better down the road, and they're going to have access to other services if we do it correctly and have supportive programs in those housing communities. So I would certainly make investments in housing. $30 million is not going to buy you a ton of housing, but certainly it's something we need to look at. After school programming for me is absolutely critical, making sure that we keep kids engaged and that we're reaching out to kids. There's this notion of active pursuit where, and we employ it at SWAG, where if a kid doesn't show up for SWAG, we go out and we find that kid and we take it upon ourselves to create an environment where that kid is going to want to come back. There's something, if a kid isn't coming, we want to know why, and we want to take steps to make sure that they come back to it. Social recreation programming, I believe is a community building initiative would be great. So I look at organizations like Christie Lake Kids Boys and Girls Club that bring kids in and actually create good role modeling for them through effective programming and through creating a safe space. Are you talking about $30 million year over year, Irvin, or are you just going to give me 30 million bucks to spend one time?
No, absolutely, 30 million a year.
Yeah,
that's roughly the equivalent of 10% of the police budget.
Yeah, well, I knew you were going there, and so there is an absolute need to have a look at the ways that we create. The ways that we deal with mental health calls, and you just touched on it. We know that the police are overwhelmed. I come down Carling Avenue every morning on my way to work, and when I pass the Civic Hospital, I see anywhere from 3 to 9 police cruisers sitting there, and I know that those people are there on mental health calls, and the police are sitting waiting for them to be seen in emergency departments. I can't help but think that if we made good investments in community-based programs around mental health to accompany police and take the pressure, let police do their work. I mean, it's an important piece of work that they do, but they will tell you that they're not experts in mental health. And it would be really good if we could actually align the mental health services with the enforcement services, divert people away from the justice system, and actually have more success on keeping people well and outside of incarceration. So, you know, if 30 million bucks, I would actually have to think about where I would put the first 30 million, but certainly we know that social programs that invest heavily in kids, after school programming, housing programming and housing supports, I think would go a long way.
Anita, do you want me to ask the second one?
Sure.
So it's also about money, because I think that's the key to solving a lot of these problems. So you talked a lot about resources, but you didn't mention the police until your response to the earlier question. You have to apply every year for grants. And I don't know how much time that takes you, but that's typical of the sorts of things that actually work to stop crime. They have to apply every year for new grants, and it's sometimes difficult to keep staff. You see this with the Youth Services Bureau and others in Ottawa. So my question is, what would you do if you had a sustained and guaranteed budget? This is your center. If you had a sustained and guaranteed budget of double your current budget, what would you be doing?
I would be dancing. You're absolutely right, Irvin. And so we do. So our health budget is pretty stable. We're applying right now. We're going through a process with the City of Ottawa where they've renewed their funding framework, and now we have to apply basically from the beginning. So we're starting from scratch, and we have to have our application in by April the 15th. And we will be. They have not increased the envelope. You know, in 2020, they had $25 million in the envelope. Now we're all competing for that $25 million and making a case for that money to be shifted around with no new investments. If I had, so let's leave my health funding aside, because that's sort of always going to be there. I could use more health funding. People that have tried to get in and get a doc or a nurse practitioner at Carlington will know that there is a wait. But at the end of the day, if we just talk about the social services budgets and the budgets that we use to address the social determinants of health, I would have way more health promoters on the ground. I would have people working actively and dedicated in communities. I would be making investments in things like food insecurity. I would be making investments in violence against women programming, where we know that there's going to be pent-up demand right now because a lot of women who are living in violence have hunkered down during the pandemic. We've heard that, but I'm expecting that there's going to be a burst of need once things start to open up a little bit more. I think where I'd make an awful lot of investments, Irvin, is in our prenatal, perinatal, and early years programming. I really think there's an opportunity in early years to make significant investments. We know about, you know, programs like Better Beginnings, Better Futures, Success by Six, the work that Fraser Mustard and Paul Steinhauer did years ago that's really driven the need to make investments in the early years and actually promote, excuse me, promote good health outcomes and good social outcomes down the road. So I'd be looking really strongly at augmenting our early years, augmenting our family supports for people who are newcomers and people who are living in social housing. And then, as I said earlier, getting into those communities and doing community development at a pace that we haven't been able to because of restricted resources. So that would be a complete blessing. The other thing we could do with more money is we could look at the way that we engage with other partners. And there's a lot of smaller organizations out there doing really, really terrific work, but it's being done on a one-off basis and being done off the sides of their desks in a lot of situations. And I really think that we could support them in a better way, acting as a community hub and allowing those smaller organizations to thrive.
Where do you get the money for the SWAG program? Where does that come from?
So it's by grants only. That's, you know, we don't get government investments for SWAG, and it's a frustration because it's a program where we've shown great outcomes. We've shown that it actually changes lives and changes trajectories. the thing that drove swag was that we found that in some of our communities there was a 42% dropout rate, and we did it by initially by postal code. We got a lot of interest from some foundations, but I think what Irvin may have been inferring in his, and why I asked if I was getting the 30 million once is a lot of grants are time limited. Yeah, we're going to give you, and Trillium is a great example. Trillium gave us $75,000 a year for 5 years to support swag, but at the end of 5 years, we were without that money and we had to go and look under rocks. So we count a lot on donations, and we've gone around the block a number of times for foundation supports of swag. But at the end of the day, it is one of those vulnerable programs where we do not have guaranteed funding going forward. If I had double the money that Irvin just promised me, swag would be one of my top investments. We would keep that thing going because we've seen extraordinary success. The other cool thing about swag is it's scalable. We could pick up swag as a package and drop it in other parts of the city and imagine similar outcomes. So that would be, that would be a blessing if we could do something like that and get stable funding.
So do they actually go to school there, or is it done now virtually, the SWAG program?
SWAG right now is virtual. We tried, we had actually hoped in the fall to be able to open up and have small numbers of kids, because the schools were still closed. We wanted small numbers of kids to come in the center, but then the lockdown went on again and we never had a chance to do that. So, and bless their hearts, they're doing the best they can, but what they really miss is the social contacts. It's ironic that a year ago we would have said our kids are having too much screen time, but now our kids are saying I have too much screen time, and they're looking for in-person social contacts.
Yeah, and they had, I remember too, some students had problems because they had to do homework on their phone. And I mean, that's very difficult to do. Yeah. So I was happy when we were able to get them the computers instead.
Right. Yeah. And so that was one great example where the Kiwanis and Staples teamed up and got us the Chromebooks for some of those students. And we tried to put them in homes where multiple kids would benefit. We have had a number of organizations step up with, with used laptops, with used smartphones. So kids are able to, get access to a certain extent, but certainly not having the SWAG classroom with its resources has become a barrier for a lot. You can't do a homework assignment on a phone. That's just that's a non-starter.
Yeah. Yeah, we were very happy to be able to help out in that area. That's for sure. So now Irvin was also asking, is there possibilities to volunteer at Carlington?
Normally, absolutely. We have about 100 active volunteers, or before COVID, we had 100 active volunteers. Since the pandemic hit, we've had very, very limited people on site. So the volunteers that we have had have been one-offs to help us with, sorting out our food deliveries and that sort of thing. Our volunteer coordinator is working from home, and she's immunocompromised, so won't be coming into the office to do that kind of screening. I'm hoping that hopefully by early summer, fingers crossed, we'll be able to start bringing volunteers back in to do some of the work that we're finding that's pandemic specific. We pivoted in a big way. We were never really in the business of food security to the extent that we are now. What I learned really quickly was how many people are living very, very close to the edge financially. So after 2 weeks missing one paycheck, for example, we were seeing people at our very, very limited food cupboard that we'd never seen before. We're now in a partnership with an organization that creates meals for us, hot meals, and we're delivering them over 200 a week. We're now up over 11,000 meals we've delivered to people in our communities since the pandemic hit. And we're hoping that we can continue to provide that service beyond the pandemic, but it's really outside of the realm of what the people that are doing that work would normally be doing. So we may have to call on volunteers to keep that going beyond the pandemic.
What would you like First Unitarians to do to support your vision?
Right. So during the pandemic, I just appreciate the opportunity to share the stories and make people aware. Outside of this, if there are people that are interested in volunteering, we would be, happy to entertain that. We hope that when we're, through this time, that we will be able to open up things like community kitchens. We have an active one in Van Lang, and we're looking for volunteers for that quite frequently. And we're looking at when our construction is done, we're going to have an amazing teaching kitchen at Carlington, where we would be, inviting people to come in and volunteer and work with our clients to create meals, take them away. And one of the main focuses of that work is to how to stretch, a food budget, and how to stretch food to continue to have healthy meals, and put things away so that you have them in the fridge and in the freezer. So that kind of stuff we'd be looking for. I think we're beyond now I think we're beyond our recruitment now for tax clinics, but we certainly look for folks to help out with tax clinics year over year. But we're in the middle of that right now. I think the recruitment's been done. And absolutely, if you're looking for a place to invest your philanthropic dollars, we're happy to give you a tax receipt.
Okay, Jane Lindsay is saying, I have a comment to make, positive about a couple of the programs.
Yeah.
So Jane, would you like to?
Yes, I would. Thank you. Cam, I just want to say that some of us have been involved with Syrian refugees, and one of the families I was closely involved with, the mom had a marvelous experience in your pre and postnatal program, and then support for the kids she already had at the same time. I think it was huge. And she's very competent and capable, and is now in fact studying nursing.
Awesome.
But it was incredible, the lift it gave her sort of spirits, and I think her grasp. I mean, she was sharp anyway, but it was really important. So thank you very much. And you had wonderful staff there. I'm sure you still do.
Yeah, we're really proud of our staff. It's been interesting through the pandemic. As you can imagine, Ottawa Public Health has done an awful lot of work, has shifted an awful lot of their resources towards pandemic response, and the casualties of that have been some of their community-based programs. So, well baby, lactation support, breastfeeding consultation, and we've had to take, some of those pieces up. And a lot of the women that are coming for lactation support are from newcomer communities. And our shameless plug, our lactation consultant is quite unbelievable in the way that she's able to navigate, cultural safety and make sure that those folks are leaving with, the best possible care. So that's one area where, as I said, when Irvin asked the question, the prenatal support for these at-risk populations is in fact massive.
Okay, and then from Maury, do all Ottawa CHCs offer such a wide range of services as Carlington, or does it vary?
So the short answer is yes. Carlington, so we have 6 in Ottawa, and we're actually in a joint strategic plan. We got together 3 years ago and said, you know what, there's more influence in numbers, and we got together and created a strategic plan based on 3 pillars, one being access to services, the second one being quality of service, the third one being leveraging our collective resources and strengths. And so we look across our one common theme across community health centers is primary care. So we all have clinics. I have 3.7 doctors and 2.5 nurse practitioners, so we're quite tiny. Somerset West has, a much larger medical team, as does Centertown. But we're all, Jack McCarthy, one of my retired colleagues from Somerset West, used to say, if you've seen one CHC, you've seen one CHC. So beyond primary care, we're all adapted to what our community is telling us they need. So for example, in Centertown, they've taken a lot of time to augment their programs for the LGBTQ+ plus community, and they do a lot of work in trans health. At Sandy Hill, they're adjacent to the market, so they're doing a lot of work in mental health and addictions, working with shelters and street involved folks for addictions, and they have a supervised consumption site there. Pinecrest Queensway does an awful lot of work in the Somali community because of the high density of Somali folks that are living in communities in the West End. So we all are adaptive, but the short answer is yes. We all have a very broad range of services, and if we don't have it, we generally have partnerships where we can find it. So it's a really excellent way of doing business, and it makes sure that nobody slides through the cracks.
Okay, the next question is from Paul McGuinness. How closely are you linked into ROH programming?
So we're linked quite peripherally. We can make referrals back and forth. We make referrals from our primary care, but the Royal, excuse me, the Royal is not so much into, excuse me, into acute care the same way that the Ottawa Hospital, the Mulfort, and the Queensway Carlton have more inpatient acute care beds than the Royal. So we do a lot of work with the Royal around consultation. We have an ACT team, which is assertive community treatment. So this is a dedicated team of 6 community mental health workers and 3 registered nurses, and they have a psychiatrist that oversees the program. And they see folks in the community who suffer with schizophrenia. And so a lot of the work that those folks do have back and forth between the Royal, because when those folks are hospitalized, there is an intake process and a discharge plan that comes out of the Royal. The Royal also works as the point for the central coordinated access for the ACT program. So all of the ACT referrals, so people with serious mental illness come through an intake and triage process at the Royal, and then get sent out to the ACT teams via that process. So yeah, we are their neighbors. We were a couple of years ago providing primary care support to some of their unattached clients at the Royal. So if a patient at the Royal didn't have primary care, we would take them on. And then the reciprocal arrangement was we got access to psychiatric consultations. So it's not as tight as I would like it to be. With Ontario Health Teams now, the health system redevelopment reorganization underway, I see the Royal playing a much more significant role in supporting community mental health.
Okay, here's another question from Irvin. Ottawa is required to develop a community safety and well-being plan. Are you involved, and what do you expect?
So yes, we are involved. We're involved as a coalition. So we're involved as the 13 community health and resource centers, and we have representatives on that focus, well, in focus groups and in the development of that strategy. There was actually a meeting on, what day is it, Sunday, a meeting on Friday that I couldn't attend that was speaking to that. What we hear time and again is that the #1 concern in our at-risk communities is community safety. People don't feel safe walking in the communities. They don't feel safe going out after dark. They worry about things like, there's this thing called environmental design when they're putting communities together, and they're worried about things like lighting pathways, that sort of thing. So I'm hoping that at a really pragmatic level, we'll see some of that addressed as communities are being either developed or redeveloped. I'm hoping that, as Irvin inferred earlier, I'm hoping that there'll be more of a press towards working with police in a different way. We now have neighborhood resource teams that are dedicated to at-risk communities. So based on certain indicators, calls for service, early development indicators from research, all kinds of things that high school graduation rates has all been put together in an algorithm, and they've created this map of communities across Ottawa that are most at risk. And we now have, I think, 5 neighborhood resource teams that are community policing initiatives through the Ottawa Police that commit dedicated officers to certain communities, and Carlington is one of them. So I'm hoping they'll augment that, and the police presence will be more around prevention and more around community building than it is currently around enforcement, and they're doing a good job. I have to say, I've been quite impressed by the way they're doing it, but I hope that's part of the planning. I guess the other things that I would hope to come out is the importance of community development and health promotion. So I think, you know, if we can get into those communities in a different way and actually have formal structures to make sure that we're, you know, following what would be evidence indicated processes, that we would make more substantial gains. So I don't know a lot about it, Irvin. It's something that's been talked about, but there's not, you know, I haven't been heavily engaged in the process to date.
Actually, now I've been asked to wrap this up, so I will now ask Irvin to thank you.
Well, thank you so much, Cam. You've covered a lot of issues. I didn't know that a PhD in hard knocks required you to be knocked down to the ground by somebody suspected of offending. But it is really good to hear you talking about adverse childhood experiences, to be talking about the determinants of health, and to be talking about the way that you're addressing those, and your focus on both mental health and prevention. It's really good to hear you talking about evidence. Anita is a great fan of SWAG, and I'm glad to hear more about it from you. So thank you so much for giving so much time, so much wisdom, and thank you for coming at a very early time on Sunday morning. I think many people will be interested in visiting the recording, because not all of us managed to get up and into a computer screen by this time. But as you can see from the questions, there was a lot of interest. Thank you so much.
Most appreciated, Irvin. Thank you, and thanks for the opportunity. And for folks that are interested, we do have a website that we're refreshing right now where you can find out more. It's going to be carlingtonchc.org. Right now, I can't even begin to tell you what it is, because it's long and complicated. But if you Google it, go on and have a look around. We do an awful lot of stuff, and I actually find out every day stuff that we do that I didn't know we do. So I guess that's a good thing.
Yeah, if anybody also wants to contact Cam, I can give them his email address and so on. So you can just ask me for it if you have any more questions, because there seem to be a lot of questions this morning. But,
thank you, everyone. We're stopping the recording now, and we're going to